It is defined as a chronic, slowly progressive, painless optic neuropathy with an insidious onset and raised glaucoma of early onset or due to an infantile glaucoma of late onset. Symptoms: usually asymptomatic until the later stages. Visual field defects. Tunnel vision and loss of central fixation typically do not occur until late in the disease. Rarely, eye ache and halos. Signs: intraocular pressure greater than 21 mmHg, high diurnal variability. Gonioscopy, normal appearing, open anterior chamber angle on gonioscopic evaluation. No peripheral anterior synechia eye, transient corneal edema. Disc changes, cup to disc ratio asymmetry, increased cup to disc CD ratio. Vertical elongation of the cup, notching or thinning, disc hemorrhages, vessels bayoneting or nasally displaced. Choroidal atrophy immediately adjacent to the disc, it may correspond to areas of retinal ganglion cell loss and visual field defects. Alpha, zone parapapillary atrophy, PPA, is more peripheral, irregularly pigmented, and less specific for glaucoma. Causes: inflammatory, exfoliative, pigmentary, steroid-induced, angle recession, traumatic, as a result of direct injury, blood, or debris. Risk factors: the risk rises with IOP, increasing significantly at pressures over 24 mm Hg, and especially over 30 mm Hg. Increasing age over 40, ethnicity African Caribbean more frequent, younger onset more severe. Central corneal thickness, diabetes. Myopia, hypertension or hypotension. First degree relative confers 1 in 8 risk higher in siblings. Steroid-induced IOP elevation, more common in primary open angle glaucoma and those with family history of primary open angle glaucoma. Differential diagnosis: ocular hypertension, normal optic nerve and visual field. Physiological optic nerve cupping, secondary open angle glaucoma, low tension glaucoma. Optic atrophy, congenital optic nerve defects, for example, tilted discs, collibomas, optic nerve pits, optic nerve drusen. Investigations: complete ocular examination including visual acuity, pupillary assessment. Baseline documentation of the optic nerves. May include meticulous drawings, stereoscopic disc photos. Formal visual field testing: Humphrey automated visual field or Goldman visual field tests. Measure central corneal thickness. Consider other laboratory workup if required. Treatment: rigorous IOP lowering commonly achieved with medications, argon laser trabeculoplasty and selective laser trabeculoplasty, glaucoma surgery. Medications: prostaglandin agonists, for example, latanoprost 0.005%, bimatoprost 0.01% or 0.03%, travoprost 0.004%, tafluprost 0.0015% QHS. Beta blockers, for example, levobunolol or timolol 0.25% to 0.5% once daily or BID. Selective alpha-2 receptor agonists, brimonidine 0.1%, 0.15%, or 0.2% BID to TID. Aproclonidine 0.5% or 1% may be used for short-term therapy, 3 months. Topical carbonic anhydrase inhibitors, dorzolamide 2% or brinzolamide 1% BID to TID. Miotics, pilocarpine QID. Sympathomimetic, dapivirine 0.1% BID or epinephrine 0.5% to 2.0% BID. Systemic carbonic anhydrase inhibitors, methazolamide 25 to 50 mg PO BID to TID, acetazolamide 125 to 250 mg PO BID to QID, or acetazolamide 500 mg sequel PO BID. Trabeculectomy with or without adjunctive use of antimetabolites, mitomycin C, 5-fluorouracil. Glaucoma drainage devices: valved, Ahmed glaucoma valve, non-valved, Molteno and Bayervelt. Cyclodestructive procedures: diode laser cycloablation, cyclocryotherapy, external cyclophotocoagulation, CPC, endoscopically guided cyclophotocoagulation, ECP. Thank you.